Well, good afternoon. Welcome anybody who's watching this recording. This is the second of the COVID conversations from St John's Church here in Farncombe. And the idea behind these conversations is that we're trying to think about the effects that the COVID pandemic has had on our community and on the world more widely, really, and to start thinking about what the effects might be on our community and society in the future. A big question, but I'm talking to a number of people who have specific areas of interest and expertise to bring to bear on this question. And so, as I say, this is the second of these conversations that I hope to have. And this afternoon, I'm talking to Dr Martin Brunet from Binscombe Surgery. Good afternoon, Martin. Thank you very much for taking your time for talking to me this afternoon. I know it's actually, you're on holiday this week, so I'm very, very grateful for you, particularly for taking the time to think about more medical things, even though you are on leave at the moment. So thank you very much.
Okay.
Thank you for sharing the time with us today. I suppose the first thing I want to ask you is, as I asked David and Shirley Faraday a few weeks ago, what effect the pandemic may have had on you personally, how it's affected the way you live your life and your family. I don't know whether you've all been healthy all the way through, or what's happened to you. How have things gone for you?
Yeah, no, thank you for asking that first. I think one of the expressions I heard, which I found really helpful throughout this whole thing, is that we're all in the same storm here, but we're not necessarily all in the same boat. And I feel fairly lucky with the boat that I'm in this storm. So, you know, like all of us, I'm saddened by the restrictions and the things I can't do. But fortunate enough, I mean, when you work for the state, at least you have a job, and that was never in doubt. And so while there was a lot of focus early on, you know, which was lovely, you know, thanking the NHS for keeping on going, I think most people in the NHS were just grateful that we had a job to keep going too. And that's been the case for me and my family, who also work in education or health, most of them, and we've all remained well. So I've just been grateful not to be in an extremely vulnerable group and to have a job, and that makes life a lot easier for me than for many people.
Okay, thank you. How did the practice at Binscombe respond? What was the sort of the timeline, and in terms of taking decisions, and what did you eventually do from March onwards?
Well, the timeline was remarkably quick, and I mean, one of the very great strengths of general practice, and it brings one of the challenges as well in terms of consistency, but one of the great strengths is that you're a small team and you make your own decisions, in a way that a hospital, you know, may have to wait for a bigger machine to operate. You're very sort of lean and nippy when you need to suddenly change. So like most general practices, we changed over a weekend really, and then embedded it into a week in terms of switching almost overnight to not a solely remote service, but a largely remote service, particularly in those early days when there was a real alarm about the consequences for a practice if a patient sat in your waiting room and had COVID symptoms.
Yeah.
You know, at the time we had no...
Which of course did happen in Hazelmere, didn't it?
Yes, I think it did. So that was very fresh in our minds, I think. And, you know, you think, well, we don't want to close over a weekend, have to deep clean. And we did have a couple of early instances with the weekend surgeries that we host, where we had less control over the patients because they're patients that come from all sorts of practices, and we were still seeing them face to face. So we had a couple of times where we had to deep clean and keep everyone safe. So there was a big emphasis to reduce footfall, in other words, reduce the number of people that were coming in the practice. We certainly didn't want big crowded waiting rooms. So we had to switch pretty quickly to, you know, mostly at least starting on the telephone, and then seeing whether people, you know, ought to be seen face to face or not. And it was remarkable how much you can do very satisfactorily on the telephone. And there were developments that were in place very, very quickly. There's again a very lean small company that helped GP practices to do texting. And they, over a weekend, gave us the ability to do video consultations, and then for patients to send us photographs of a mole or a rash or something, which was tremendously helpful and still is tremendously helpful.
Okay.
So big changes. And I mean, what was amazing in those early days was actually the demand from patients was a lot lower. People were not to come and see us about things that could wait. And so that actually was quite helpful, because we had so many meetings to just think, how do we do this? How do we organise this? How do we get our PPE? How do we keep everyone safe? How do we see someone who has got a fever when obviously we don't want them in the practice, and we had to juggle other ways of seeing them. So it was interesting times. It was difficult, but it's nice to be part of a small group that work well together and can function as a team and then change things very quickly. And the other big thing that was on the cards anyway, some of these things were developments in general practice anyway, but again, just embedded more quickly, was using the website for online access, so that people can fill in a form if they want to contact a doctor or a nurse or reception. And all practices were doing that, and in place of doing that, and we've all done that in slightly different ways. But again, that's been a really helpful innovation that would have happened without COVID, but probably happened more quickly and more thoroughly with COVID.
I actually had cause to use that over the course of the summer. I forget exactly when it was. I think it was July or perhaps very early August, and it all worked very, very well. And I was quite surprised, actually, because I got an appointment to see Dr. O'Connell the very next day, which doesn't normally happen. And I thought, oh, this is much faster than usual. And I remember saying to him, I expected to have to wait for ages and ages. And he said, well, it's just the luck of the draw, really. And I became aware that there were differences between different practices across the country, and people that I knew in other areas of the country were saying, "Oh, you can't actually get in to see anybody, and it's all very, very difficult." Presumably, there are different constraints that operate in different places and on different practices. But what sort of things could guide a GP practice in terms of how it takes the decisions as to how it's going to respond to the circumstances that you all faced?
Yeah, I mean, I think this again comes down to the fact that each GP practice is its own little organisation that can make its own rules and come up with its own way of doing things, which is a very great strength. But it also means you can get big variety, and a lot comes down to the philosophy of the practice, I think, and how you want to operate. And there has been a lot of frustration among GPs, where if you read certain newspapers, you get the impression that we've all just been closed and we're not seeing anyone, which has never been the case. All practices have seen people face to face where required since March. But I think the threshold for what we would deem justifies face-to-face appointment has probably been quite different in different practices. So some will feel that they should only really be seeing people face-to-face when there's a real clinical necessity. And in fact, our health secretary is very much of that view, that that's the way it should be done. I think that's more to do with his sort of philosophy of enjoying remote access and technology. He's very renowned for liking technology rather than great worries about spreading the virus. But so some would say, well, it's only really if we've got to do an examination that we couldn't possibly do over video or over the phone. I think we've probably more at Binscombe or the other end a bit, in that we see a lot of value in face-to-face consulting still, and that might be just because you could do a video, but it would be done face-to-face. And sometimes it's just because of the connection you get with someone when you're in the same room as them, which you wouldn't get over the telephone. So, there are times when that's just too important. And actually, the risk, I think particularly once shops were open again and you could go and see the hairdresser and get your hair cut, you sort of think, well, well, actually, the risk of coming to the practice, now we've got a good system for making sure that anyone with any COVID symptoms is seen outside of the practice in some porta cabins that we've set up. The risk of coming to the practice is pretty small.
Right.
You know, we're both going to be wearing masks. There's no big queues in the waiting room. So, you know, there are times where we think in this instance, it's really important to have that connection, and the patient would really like to see us face to face. You know, we're going to go with that. Other practices have a different view where they say we should be reducing any risk at all, and therefore they'll only really see people if they feel face-to-face is essential. So you differences in how practices operate, and that's part of the joy and the frustration of general practice.
What would you say the impact has been on other tiers of healthcare? I know that we hear a lot about, for instance, the steep decline in the numbers of people accessing A&E at general hospitals, impacts on the mental health care system, with it being very, very hard to support people in the way that they have been supported in the past. What's your impression? What are you hearing at the surgery?
I mean, I think this is enormous, and probably the biggest health impact, really. You know, if I think of my own patients who have had health impacts due to COVID, significant health impacts due to COVID, you know, of my own patients, I've got about 1,400 patients. I can probably think of less than 10 that have had a significant impact from COVID, whereas there are countless whose health has been significantly impacted by the restrictions and the effects of COVID. Now, that's not making any comment as to whether the restrictions were justified or not, but that is the reality, that's had a more widespread impact. So mental health has been enormous, and not necessarily impacting secondary care mental health services, but certainly, you know, big thing that we've seen. Seeing a lot of people with anxiety, particularly some people very low going into the restrictions and lockdown. Some people had no problem going into lockdown, but found it extremely hard to come out because of anxiety and go back into the world. So that's been very big, and I think the legacy of that will take a long time for many people. Not for all. Some will recover very quickly from that. Some will take a long time.
Yeah.
And then, you know, there was a big drop in demand for A&E and for general practice initially with the first lockdown. People were I think, one, respectful, thinking, well, I'm not going to go with something unless it's really important. And secondly, you know, very wary of going. And some of those will have been minor illnesses that just got better on their own, and that's fine. And others will have been, you know, things where there may be a long-lasting legacy of people that have ignored symptoms or been too worried to see someone. And so again, we won't see that impact for a long time. I mean, the other big impact that we're seeing now is, you know, so many operations got cancelled. You know, there's a lot of people that, you know, have waited longer for their knee replacement, their back surgery, their whatever, things that are apparently routine because they're not cancer related, you're not going to die, but, you know, living with that level of pain, you know, maybe getting a bit stuck on painkillers. You know, there's a lot of implications from that, and I think that will take a long time to iron out as the hospital just has backlogs. And I think the other problem is backlogs have kind of become acceptable in that you can blame COVID. But we've got to make sure that doesn't become an excuse just to have inevitable backlogs. And certainly within mental health, severe mental health, I think the ability to get support, especially for children and young people, is not in a good place at the moment. Waiting times are far too long. And, you know, the discrepancy between mental health service and physical health service has never been greater, sadly. There's a lot of talk about trying to bring them on a parity. It has been for years.
Which of course we were talking about long before this all happened, and this has just made it more acute than it was before.
Yes, I think so. sadly.
In terms of the future, how do you see things developing within or for the practice? I mean, we all talk quite blithely about things getting back to normal at some stage. Will we ever be sat up again
Yes.
in a waiting room at Binscombe surgery with people coughing all around us and babies running around crying, that kind of thing? What's normal going to look like when it happens?
Yeah, that's a really good question. I think I think once, hopefully, the vaccine will mean that the R number will come down and cases will drop significantly, and we'll all be able to be more able to just mix in a way that's a vital part of humanity, and do that, enjoy that part of being human again. You know, you look at things on television, or a football stadium or something, and maybe it was pre-lockdown, and you think, oh, all those people in one place, how terrifying. And we've been conditioned to be afraid of crowds and flinch when we see them at the moment, and we'll need to be deconditioned. But I think for the majority of us, that will gradually fade, which will be a really good thing. So much as, you know, I don't particularly want people to be coughed over in the waiting room, the normality of not feeling anxious when you're sitting near someone is something we need to restore, because that is just part of being human. So I think some things will get back to normal. It will be easier to get a face-to-face appointment in all practices. We'll be less nervous about you know, who we're sitting next to. In the practice, you know, we did an audit of things that we, or more a practice survey among the staff of things we'd like to keep after COVID and things that we want to get rid of. And PPE was top of everyone's list of something we just want to get rid of, because it's such a hassle. Absolutely. And you know, particularly wearing a mask with a patient is it interferes in the interaction and the consultation in a way that is necessary at the moment, but we would be overjoyed to get rid of that. So, you know, as soon as we're no longer required to do that, I think, you know, we'll be wanting to get rid of it. Obviously, if there's a particular patient that would feel less anxious if we were wearing a mask, we'll pop a mask on. That wouldn't be a problem. But I think most patients will want us to go the other way. Yeah. So that, you know, there will be a heading back to the norm. So I think there are some things that have come from COVID that are quite positive and that we'll want to keep in general practice moving forward. So, for instance, we didn't used to have booked telephone appointments before. You could ask the doctor to phone you, but you wouldn't know when we were going to call. And now, you know, you can book an appointment 2-3 weeks in advance for a telephone appointment on that day, and that, for a routine matter, might be tremendously convenient for you. And I think we've realised actually there's a lot you can deal with on the phone that works brilliantly and more convenient for the patient. They're not hanging around in the waiting room. If you're running 20 minutes late, they can get on with whatever they're doing. It's not such a deal. So that can work really well. Things like, I mean, it's interesting, video consulting hasn't really taken off. It doesn't add that much. Most of what you can do via video, you can do on the telephone, and actually the quality of image you get with a photograph is far better than anything you can see on a blurry video. So while we'll always have the ability to do video consulting, I think it will always be a rarity. Whereas being able to send the patient a text and say, can you send me a photo of, you know, your red eye or whatever, is tremendously helpful. And for straightforward matters works brilliantly. So that will be a good thing to keep. So I think we'll do a bit more remotely, but it will be great to get back to doing more face-to-face without all the challenge and the bother.
You mentioned a couple of minutes ago about some sort of attitudinal changes about people getting used to being among groups of people again without it being a matter of being scared of it. And I'd like to think about some of the, I suppose, more attitudinal changes to do with people's health and so on that might have come out of this. And one of the things which has struck me is that although this has obviously not been a good experience over the last few months, but nevertheless, I do feel that we sort of got off relatively lightly, really, in comparison with how things might have gone. I mean, certainly comparing it with some of the pandemic outbreaks that have happened in the past, this has not been as severe as, you know, certainly the flu pandemic in 1918 or anything like that. Obviously, a very different situation in terms of what we were able to do. But the vaccines that are coming online now have been developed incredibly fast. And I know that that's partly to do with the fact that so much of the groundwork was already laid in terms of dealing with SARS and MERS and so forth.
Yeah.
And given that the government was, in terms of its emergency planning, was envisaging if there was going to be a pandemic outbreak, it would be flu rather than what we got. Might we be caught out by something that comes completely from left field again in the future? And is that something to bear in mind? Do we need structures and arrangements and plans that can actually deal with something like that again, do you think? I know it's a huge question, but
it's a really
what's your perspective on it?
Yeah, I mean, I think the one thing that was very different, I mean, obviously none of us were around in 1918, but seems to be very different to this pandemic is not the virulence of the virus, which I think there have been more virulent pandemics a long way, but the global response and the fact that every world leader knows what every other world leader is doing, and the media scrutiny has meant governments have had to make decisions in a cauldron, really, which has been very challenging. And I hope that at the end of all this, we can have a very balanced view of how do you lock down, when do you lock down, what's the balance of harms between lockdown and not. So I agree with you that I think we've got to weigh lightly in terms of, a virus could be more virulent, could kill, the actual percent of people who catch coronavirus and die from it is lower than with other pandemics, without a doubt. But the overall impact on our global world has maybe been bigger than even in 1918. Hard to compare the two. But, and that, you can't have a year like 2020 every third or fourth year and function as a society. So, we're going to have to hold that in perspective. But I think in terms of the virus, I mean, one thing, some people have had concerns about the virus about the vaccine, thinking, it's been developed so quickly, how can we be confident about it? Hasn't it been rushed? But I think actually it's very different. I mean, one of the reasons why vaccines take quite a while is you've got small teams, and if you need to recruit however many thousand patients, that's hard work for a small team, and it takes a long time. Whereas so many labs, everyone was diverted to COVID vaccine research, and there was this enormous push to it. And there was also the will among the public to get it done and help out. Lots of people volunteered for the vaccine trials because they wanted to do their bit to help the research as much as anything. So there was, the amount of person hours put into it was enormous, which allowed it to happen quickly. And you're also dealing with something where you can tell if a vaccine is going to be effective fairly quickly in the middle of a pandemic, in that you can recruit people quickly, you can measure their antibody levels pretty quickly, you can then see how many of them get the virus while it's circulating. So it's not like you have to wait 5 years to see whether you've altered the progression of a disease. You can actually do these things quite quickly. So, and developing a new vaccine for a respiratory virus is something that has been done a lot. I mean, with flu every year, with SARS, with MERS. So I think the only way we'd get really caught out and really stumped would be if you had a virus that works in a completely different way. So, we still don't have an HIV virus.
Yeah, quite.
HIV vaccine, sorry.
Yes.
And that's because the HIV virus basically joins the DNA in white blood cells, and therefore is incredibly hard for the immune system to detect. Whereas respiratory viruses, none of them do that. They're available for the immune system to work on. Similarly, we don't have a malaria vaccine. Well, that's because the parasite causes malaria is a completely different type of organism. And
malaria has been around a good long while.
It has, but I think there are unique challenges with those organisms that make it really difficult to get a vaccine. So a respiratory virus is always likely to be along these lines.
Yeah. Okay.
I mean, what we don't know about the vaccine is how long will it last? Will we need boosters, that sort of thing. But if you can vaccinate enough people, you should be able to get, that precious herd immunity without loads of people having to catch the illness, and that should make a big difference. And then we can worry about, do you need it annually or not down the line, can't we?
Another thing that I was thinking about was that given the speed and effectiveness with which we've been able to develop these vaccines and treatments, is this going to alter people's expectations in terms of medical research and science in the future? Last Friday, I think, I heard a scientist on the radio being interviewed who was working in the area of Alzheimer's and research into dementia. And she said, well, if the kind of resources that have been directed towards COVID research over the last few months had been put into Alzheimer's research, we'd have an effective treatment by the end of a year. Are people's expectations going to be altered? Are we going to start saying, well, it is possible now for us to move much quicker than we thought we could? And are these realistic?
Yeah, I think expectations might be altered, but I'm not sure they'd be realistic. And if you were an Alzheimer's researcher, you probably would say that, wouldn't you? Hoping everyone would pile money into your area. But so for instance, something like Alzheimer's, you could put a huge amount of money and time into that and still not get a cure. Yeah. If you look at neurological diseases, one thing medicine has been really poor at making any breakthroughs in is something that repairs nerves that are damaged.
Okay.
We've got a little bit of treatment to try and prevent multiple sclerosis from progressing. We've got some treatment that improves the symptoms of Parkinson's, but it doesn't affect progression really. And so you just look at that field of research and think, that is an incredibly hard nut to crack. We've never made big, it doesn't mean we shouldn't keep trying, but to actually come up with something that really prevents the degenerative nerve disease of Alzheimer's is incredibly difficult. And also, you're not going to have a cure by the end of a year, because if you want to know whether you've got a drug that prevents progression of Alzheimer's, you're going to have to give it to people for 5 years to see whether it makes any difference. So some diseases are on a different timescale. But having said that, I think Western society has been in love with the idea of the silver bullet, the drug that's going to cure all ills, or every ill will have its cure for decades. And we're a bit addicted to that. And we like the idea that we can do whatever we like. And, doctors will cure us. And, it can be it can be an individual shock and sometimes a societal shock to realize that actually medicine can't do anything about that. There are many diseases where we'll say to someone, we know what it does, we know how it affects people, but we've no idea what causes it, and we've nothing to cure it. And that's in 21st century medicine, and
indeed,
got a long way to go. So some of these things we may find we can never cure. Now, we should keep doing research, but I suppose, with something like Alzheimer's, for instance, while research is really important, I think what worries me a little bit about that sort of mindset is that it says it can take the emphasis away from what people with dementia really need, which is understanding, support, families learning how to manage, all that infrastructure, and really sort of non-sexy stuff of just having people that can come alongside you and help you, and that humanity stuff. It's not as glitzy as the drug that cures Alzheimer's, but it's probably far more important for a disease like that.
Yeah. And that, I suppose, brings us on to the last thing that I had in mind to think about, which is the relationship between the individual and societal, and how far our experience of the last few months might shift that. It struck me that there are all sorts of contradictory things which might come out of this experience. On the one hand, we have the experience of something which has come completely out of left field and has knocked the whole of the world to one side. On the other hand, we also have a new experience of governments doing things that they said they could not do. And it was not possible to do in terms of spending money and in terms of social organisation, and all sorts of stuff. And that leads me to reflect a bit about the way our attitudes to health on a very basic level are in this country. We're very unusual in terms of developed countries of having what is effectively a socialistically organised healthcare system. We have the NHS, which is funded by taxation, and virtually no other developed country, I think, does that in quite the same way. It might be us and Cuba. That's possibly about it. But every other country has a balance of private provision and insurance in a very different way from the way that we manage it. On the other hand, I think it's fair to say, we still think of what happens to our own health in very individual terms. You know, it's us that gets sick. It's a discrete little problem which the health system deals with. And what comes out of the pandemic and the situation that we've been in over the last few months is the extent to which our health relates to what the people around us do. And that we're not necessarily just little individual isolated blocks, but in fact, we function as a society, and the decisions that we all take have an impact on all of us, not just on ourselves as individuals. I don't know whether you'd like to say anything about that. As I say, that's my thought. I don't know whether it will have any great effect on the way people think or behave, on the way things are organised, on the way attitudes pan out in the future. But it strikes me that is a possible lesson that one could draw from what's happened to us.
Yeah, no, I mean, definitely sociologists will be unpicking this for years to come, won't they? And you know, there have been some lovely examples of people looking out for each other, communities trying to come together. I mean, what's frustrating is if we were fighting something else, we'd have come together much more literally to, you know, to tackle this and support one another. And yet, you know, we haven't been able to do that in a literal sense very, very often. I think, I mean, as far as the NHS is concerned, I think it has sort of reminded our country how much we do value it. I think, and yeah, it's been interesting to see how much money is poured into things. We've found the magic money forest, haven't we?
Indeed.
Which will make it interesting moving forward. You know, I think it will be harder to just go straight into an austerity agenda than it was after the crash, but who knows? I think one of the big challenges in this situation, though, was that the different risks of COVID versus lockdown are felt by different sections of society, and that's been very tricky because that has the potential to polarize. So
that's very
those are most at risk of COVID, the elderly, those who have health vulnerabilities, do not overlap that much with those who are most at risk of lockdown. The younger, the working, you know, people who are healthy but are no longer able to survive economically. And that's made it really difficult because, you know, if you're angry about lockdown, you know, you're potentially putting lives at risk of people who, you know, are vulnerable. And if you're angry about people not locking down and trying to keep their business running, then, you know, you can be accused of not caring about the future of the young. And that's been a real tension in our society,
indeed.
Which has, you know, it's been well debated. But, you know, as we saw with you know, generational divide over Brexit, for instance, there's a danger of a generational divide over should we lock down or should we not, which I don't think has torn our society quite like the Brexit debate did, but has the potential to.
I think you're right. that was pretty much all I had on my mind. So thank you for all of that, and thank you for throwing those thoughts around. Is there anything that we haven't covered that you think is worth mentioning at the moment?
No, I think we've covered things well. I do think that we shouldn't call it normal until, for me, certain things, I need to see them happen again before I could really say we've recovered from this. And that will be things like a family party with as many people as you can get in your garden as you want. It'll be like a church full with everyone singing at the top of their voices. Yeah. And it will be a football ground full of 50,000 people that are allowed to shout and cheer without masks, standing next to each other. And just look forward to the day of all of those happening again.
Absolutely.
Mustn't rest till it happens, I think. Yes, we can't do those at the moment, but hope we get there soon.
The time will come again.
It will.
Martin, thank you very much. I really appreciate you spending the time with me. And carry on the good work once your holiday is over.
Yes, I will. Thank you very much. And you as well, James.
Okay.
The church has a really key role to play now and in the future.
Thanks very much. God bless you and good afternoon.
Okay, good afternoon.